Hello everyone, thank you so much for getting into the room. I would start precisely on time because we have a lot of topics and cases to be discussed and share with you. So I would prefer to sacrifice my introduction but not the following speaker's part because it's very interesting and I hope it's going to be very interactive. Take the seat, stop chatting with your colleague of yours. Because we have a wonderful session to be shared with you. This is the program. I have the privilege to be shortly introducing the symposium, and then we have 4 exceptional speakers who are going to share very interesting cases. And last but not least, I would encourage you to ask questions, making any comments, either by getting access to the microphone, which are everywhere in the room, or otherwise just raise your hands and we'll be reaching you to the microphone. Or if you want, post the question online and our friend Edesh is gonna be your voice. Now, these are the session objectives, which I'm gonna skip for today. You can read them if you want. They are in the program, they are available, but I would like to actually ask ChatGPT for the key question that is being discussed and raised with you today. One week ago, when I was thinking about the session, I asked ChatGPT what are the main determinants of the outcomes after PCI. And ChatGPT can almost do the job better than what we can do. And this is the answer that I got from ChatGPT. Sorry, madam. Can you please... So ChatGPT said patient-related, procedure-related, and post-procedural related factors. I'm not going to go through them in detail. There are age, diabetes, CKD, heart failure, ACS at presentation, frailty, which is, of course, an added risk factors on top of age. Those are procedure-related, and those we know very well. The lesion complexity, bifurcation, CTO, left main, multivessel disease, long lesion, small vessel, the reference vessel diameter is also playing a role, the extent of CD, the SINTA score, which is or not being used very well, the stent characteristics, and ChatGPT here limits itself to DES versus bare metal stent and first versus second generation DES, does not go any further, and perhaps we should do that in 2025. The procedural quality, how the stent is implanted, where and how, of course, and most importantly, also long-term factors, post-procedure items such as pharmacology after the procedure, and how the patient is actually controlled with respect to risk factors and rehab. So my key message out of this very complicated answer from ChatGPT is twofold. First, we should actually praise ourselves because our job of interventional cardiology is not easy. We have to control a huge amount of factors, intra-procedural, pre-procedural, post-procedural, and it's not easy. And that's why we are here to learn from each other. Second point to be discussed in 2025 is whether all DS are alike or whether we could think about a good reason for choosing one technology versus the other. And we are going to discuss in this case multiple stent technologies, among them the one which is being highlighted here on the screen, which is Cre8 EVO. You can say whatever you want, but Cre8 EVO is for sure a unique stent for multiple factors, mainly those which are summarized here. First, it has no polymer. It's not just a durable polymer or a compatible polymer or a bioresorbable polymer. This is unique. There is absolutely no polymer. And the way the drug is released in a controlled fashion is through this amphibious formulation, which is extremely interesting, and I'm going to expand on that shortly. Plus, it is carbon-coated, which makes the stent extremely biocompatible and very less prone to interaction with the coagulation factor. If anything, our mechanical valves are all carbon-coated for that reason. I was alluding to this amphibious formulation, which is extremely smart, for 2 reasons. First, the combination of sirolimus plus a free fatty acid allows sirolimus to be released in a very controlled way, not as a burst during the implantation, but in a controlled way. And we know how important that release is in terms of kinetic over time. many important data on that. And then the fatty acid is actually playing a very interesting role of the Trojan horse, especially in diabetic patients. Because of insulin resistance, the metabolism is completely dependent on fatty acids, and diabetic cell free acid turnover is increased. By uptaking more fatty acids, the diabetic cell actually incorporates more sirolimus inside the cell, which is, of course, acting where it's supposed to do, inhibiting, by doing so, cell replication. And if anything, and I would like to challenge you, if you think I'm wrong, please raise your hands and let me know. There is no evidence apart from Cre8 EVO which is telling us that in diabetic patients, the performance of the stent is in fact extremely consistent in diabetic versus non-diabetic patients. First, in terms of late loss, as shown here, the late loss in diabetic patients with Cre8 EVO is identical to the late loss in non-diabetic patients, which is at variance with what we have seen throughout all second-generation DS. And second, to the best of my knowledge, there is only one clinically powered study showing that one specific DS is better than another one in diabetic patients, and that the evidence is in favor of Cre8 EVO and is coming from the SUGAR study, which is an investigator-initiated and independent study, multi-center study performed in Spain. Here you see the result at 1 year follow-up, which were basically reproduced at a much longer time frame. And finally, of course, the engineering part, the mechanical component of the stent, of course, plays a role. At the end of the day, we are a sophisticated plumber, unfortunately, that's what we are. And I would like to make a few comments about the technicalities of the stent. First, the side branch, the engineer part is extremely wide, and that allows very easy access to the side branch when a bifurcation needs to be treated. And we are going to see a clear example of this. Second component, which is perhaps not that well understood by many, is the fact that based on the engineering component, or how you link the two components of the cell, if the link is from peak to peak, if you expand the stent, of course, you have a compensation into a longitudinal shortening of the stent. The more you expand the stent, the more the stent shortens itself. If you are mid-to-mid like Cre8 EVO, this shortening is zero, which is an extremely advantageous component, because this one, in combination with the fact that we have proximal edge markers, allows very precise stent positioning. So with that said, it's my privilege to call upon the first speaker, who is Dr. Wang from South Korea, walking us through the first case. Thank you very much for your attention.
Yeah, thank you for your kind introduction, Chairman. Good afternoon, ladies and gentlemen. I'm Dr. Hwang from Seoul National University Hospital. Today, I brought one case with the left main bifurcation PCI. So I have nothing to discuss on this case. Let's move to the patient. This patient was 64 years old male patient, and he referred from another hospital due to the effort angina for 5 months. He actually already received anti-angina drug, but his symptoms remained. He had high diabetes, hypertension, and he was a smoker at that time. And ECG finding and echocardiography finding in a hospital was normal. This is his angiography. We can see that there is a tight stenosis at the middle part of the circumflex, and more than 70% stenosis at the circumflex ostium. And from the proximal to middle part of the LAD, there was a diffuse stenotic lesions up to 80 to 90% stenosis. For the ICA, there was some intermediate lesion at the middle part of the ICA, and there's a tandem lesion at the PDA branch. So syntax score of this patient was 35, favoring KBH, and based on the syntax score 2, both KBH and PCI were recommended.
Thank you very much, Dr. Wang. So why don't we stop here for the first break, and it would be my privilege to ask your opinion. You have seen the case. It's, at the end of the day, a relatively complex three-vessel disease with a SINTA score of 35, yet a SINTA score 2 actually pretty much telling that there would be an equipoise between PCI and CABG. So by raise of hands, try to be as fair as possible here. Who would send this patient to surgery? Okay, that's an interesting one, not few. And what about PCI? Actually, surgery is almost prevailing here. I would say not almost, it's prevailing. Many would have not voted, but surgery is prevailing, which is interesting because it means that the anatomy complexity per se would dictate the decision-making and not the combination of anatomy and risk factors, which is what the SINTA score 2 tells you. So why don't you tell us what you did here?
Okay, in this case, we decided to do the PCI because we thought that angiographically there was no severe calcification and we could achieve the optimal PCI to the patient, even though the PCI can be difficult. And also, basically the patient didn't want to receive the CABG, so we proceed with the PCI. For ICA, we measured the FFR, and the FFR value was 0.94. So we could safely defer the mid-ICL lesions. And for the PDA tandem lesions, we thought the substantive myocardium is not so large and the lesion was not so tight. So that's why we defer the PDA lesions. For ACA, middle part of the ACA, there was a tight stenosis there, so we decided to do the PCI. And for the left main, we did the IVUS, and we can see that there was a low lumen area, 2.9 at the circumference ostium with the large plaque burden, around 80%. And in the distal left main, there was also large plaque burden, around 80%, with the lumen area of 5.5. So after this IVUS, we decided to cover the distal left main to the proximal circumflex and another tandem lesion at the middle part of the circumflex. For the LAD, there was a diffuse lesions here, and with the abundant plaque burden. And the most severely stenosis area was B in this distal cut, and the lumen area was 2.6 with the plaque burden 82%. And this is not a moving image, but when we see the moving image, we can see the tight stenosis at the mid to distal part of the LAD. And that area, lumen area, is only 1.36. So we decided to cover the whole lesions at the LAD. And also we have to consider about the LAD ostium. And LAD ostium has a large plaque burden with a 77%, and the lumen area was 4 square millimeter. So when we do the crossover stenting from the left main to the circumflex, we have to think about the jailing of the LAD ostium. So we firstly decided to do the bifurcation 2 stent technique with the DK crush. So our plan was DK crush to the left main and put another stent at the middle part of the circumflex and cover all lesions in the LAD. So we started from the circumflex, and we pre-dilated the lesions with the semi-compliant balloon at the mid part of the circumflex and distal left main to the proximal LAD. And then we put the stent at the mid part of the circumflex. And then we moved to the LAD. And we also pre-dilate whole lesions with the semi-compliant balloon 3.0 by 15 millimeter from the mid to distal part of the LAD to the distal left main. After that, we thought that the region was well prepared, so we put a long stent at the mid to distal part of the LAD. However, after stenting, the second diagonal was jailed, so we did a kissing ballooning between the LAD and the second diagonal. And then we can focus on the left main bifurcation. We put a short stent here from the distal left main to the circumflex with the balloon for the crushing. And after stenting the circumflex stent, we crushed the stents with the NC 3.5 by 50 millimeter. After that, we rewired the wire from LAD to the circumflex, and you can see that here, the wiring was not so difficult in this case. So we thought this might be the unique feature of the Cre8 because it has a homogeneous stent structure with a rectangular shaped cell. So this can be more easier rewiring. After that, we did the kissing ballooning between LAD and the circumflex using the 2 NC balloons. And then we put the last stent here from the distal left main to the mid part of the LAD. And during this procedure, radio-opaque marker of this stent was so helpful to position the stent. And also, another feature of the Cre8 EVO was the no stent for shortening in this stent, so we could put the stent with some confidence for the right position. After stenting to the left main to the LAD, rewiring was done, and we did the final kissing ballooning to this patient. And also, during this process, the radio-opaque marker was also helpful to position the balloon. And then we further dilate the LAD stent with a semi-compliant balloon, and we could get this kind of result. You can see that there is some under-expansion at the mid part of the stent. And this is the final PCI, final angiography, and you can see that the left main bifurcation PCI was well done, and there is some remaining under-expanded area at the mid part of the stent. So we did the EVO here, and we found that the stent area was so successfully improved with the left main bifurcation PCI, meeting all the EVO's criteria for the left main bifurcation PCI. And for the LAD, our concern was this underexpanded area, and the lumen stent area was around 7, and this is more than 5.5 in the literature. And also there are several branches here, so we have some concerns about doing more ballooning to this area. So we did not do further ballooning here. And another concern was there was some underextended area at the distal part of the stent, and stent area is only 4.9. But if we have some more balloons to use in this case, I think we did further ballooning to this case. But in Korea, due to the insurance program, we cannot use more balloon here. So if I could use more balloon, I would took 2.75 NC balloon to further optimizing these lesions. So this is my last slide. For deciding the treatment strategy, I think that the physiology and imaging may be very helpful in this kind of complex patient. And also in complex PCI, imaging-guided PCI is very essential. For the stent issue, Cre8 EVO has a high radial force, so it is feasible for the left main bifurcation PCI. And the unique feature of Cre8 EVO, no stent for shortening and radio-opaque marker, make patients confident in implanting the stent in the right position. Lastly, Cre8 has some different stent structure, so it makes the patient to side branch rewiring easier. Thank you for your attention.
Thank you very much, Dr. Wang. So I did not fully understand. So the limit of balloon has been reached, and therefore you could not use another one, or was a limit in pricing of insurance coverage?
Actually, in this kind of left main bifurcation, two stenting in Korea, we can only use the 4 balloons for the PCI. So we already used the 4 balloons. So if we do more ballooning to the distal part, I think we need more balloon at that time. So we could not do that.
Wow, that's a good. You must be very detailed.
Yeah.
I would make just one question about the procedure. If I well understood, you covered before the proximal part of the left main and the LAD, and then you performed a stenting on the distal part. So?
Oh, no. We first put the stent at the...
You cover before the proximal part and then the distal part, or not?
Oh, no. We put the stent at the distal part of the LAD first.
The distal part and then on the proximal part.
Yeah,
okay,
yes.
Okay, perfect.
Wonderful. In the sake of time, I would thank you very much, and we would continue then with the second case. We are walking our rope from complex multivessel disease into perhaps an even complex case because it includes a CTO, and we have the privilege to have Salvatore Colangelo walking us through this second case.
Oh, sorry. I'm sorry. So, good morning, everyone. First of all, I would thank the CID for the kind invitation, and particularly Enrico Roveda for his really extremely hard and dedicated support. My role today is to present you a complex PCI with guiding extension catheter use. I have no conflict of interest. This is the history of the patient. It's a very long history, 69 years old male with all the risk factors that you know, that in April 2005 received the first DES cipher on middle AD for an acute coronary syndrome. In this procedure, also the right was treated with a balloon. Some months later, the patient was once again readmitted to the emergency department for acute coronary syndrome, and for the angio showed instant restenosis on LAD, and the patient received another DS, Taxus stent, on the middle AD, and during this procedure, a successful attempt to recanalize the CTO of the right was performed. Patient was well for 5 years. In July 2010, he had an anterior STMI. Once again, we had an instant restenosis of LAD, but in this case, just ballooning was the option with no DCB, just balloon to reopen the two stents occluded. All well, up to December 2023, the patient developed CCI3 angina, performed a SPECT that showed an inferior lateral ischemia with normal ejection fraction. And in February 2024, the persisting of angina and dyspnea, together with the ischemia demonstrated at the SPECT, was for me an undoubtful indication to RCA CTO PCI. This is the angiogram of February 2024. You can see the very good results and optimal T3 flow on the LAD, probably a mild restenosis, but no indication to retreat the LAD. This is the right, occluded in the proximal segment with the homolateral recanalization of the distal part. We performed the dedicated CTO angios during the attempt of recanalization of CTO. This is the epicranial view. Sorry. This is the cranial view of the right, double injection. So first the donor vessel and then the coronary occluded, and this is the RAO segment. You can see some collateral coming from the septal, but you need to know that the septal come and start from the stenting, so stenting zone. So sometimes it could be not easy to go in with wire and microcatheter. There is also a very good epicardial channel, too much distal, but good collateral coming.
Thank you, Salvatore. Perhaps,
how would you treat?
Yeah, perhaps before you disclose us what you did, I would say that it is not a surgical case, right? LAD is perfectly okay, left system is perfectly okay, so we just need to reopen CTO. Sorry for that, Salvatore. The question is, who would you try anterograde to begin with as a first attempt? Anterograde. Okay, despite proximal cap being relatively ambiguous, who would try retrograde directly? Okay, anterograde seems to be winning, Salvatore. What pathway did you choose?
How I treated the CTO, I start immediately from the retrograde wire because there is, as Marco said, an ambiguous cap of the antegrade, and normally when I do a retrograde, it's always apart antegradely, so I start with the retrograde, but I know that probably at this time during the procedure I need to go antegrade in order to go with the re-enter or the combination of the two wire antegrade and the retrograde. This is the crossing of the septal bar with the Sion blue, and considering that I had the opportunity or the option to go with an epicardial, very long, very distal collateral, I use a very long microcatheter, 162 Pro-Navi microcatheter. The Sion blue went very well into the septal, and after that I push forward the microcatheter along the Sion blue into the PDA. After that, I swapped the Sion blue with a Gladius, and this Gladius wire went easily up to the mid-RCA. At this point, I had the preparation of the antegrade part. With the Sion blue, I go into the proximal RCA, and there is a conus branch starting in proximally, and I put the wire exactly at this point. After that, I do a reverse cart, guiding assisting reverse cart. So using a guiding catheter, I dilate a balloon just at this point proximally to the proximal cap of the occlusion, and after the predilation of this part, the gladius, and I create a connection between the two parts, with the subintimal probably, or to the distal to proximal segment, and the gladius went really, really easily into the guiding catheter, as you can see. And after that, when I have the gladius wire into the antegrade guiding, I anchor the wire with a balloon, and I push forward the microcatheter into the guiding to externalization with a long RG3 wire. So I do this. I have the RG3 wire both in antegrade and retrograde wire, so a multiple predilation with a 2 and 2.530 balloon, a non-compliant balloon was performed from distal to ostium. And I start with stenting the distal part of right with a 2.540. After that, there is no way to go with any other stent along this RG3 wire, so I need to go with once again with the GEC distally, with the guiding extension catheter, and I use this technique, the balloon-assisted tracking, so I inflate a long semi-compliant balloon under mid-RCA, and then I push forward the guiding up to the distal right. At this point, I easily implant two stent, 346 and 3513 on proximal and ostium right. This is the first check after stenting. The PL was still diseased, and distally to the first stent that I implanted. So I decided to go with a new stent, 225-33, through the guiding extension. You can see, you can appreciate the crossing of the stent along the transitional part of the GEC up to the distal. I insert the Cre8 EVO by deep engagement of this GEC into the stent, all the stent that I already implanted, and after multiple post-dilation of the stent with 3 and 3.5, this was the final result of the right. Sorry, I don't know why it starts. So for me, it's a very good result with no optimal altimetry flow on postural and also on the PDA branch. So my conclusion is that during the CTO PCI, GEC guiding extension catheter played a role both for the retrograde wire re-entry with a reverse cart, but also for the forwarding of DS into the distal segment RCA, where I cannot go just with the wire. The GEC conforms easily to the natural tortuosity of the vessel, assuming an oval shape when navigating in bends or partially constrained. This layout adjustment may result in a reduction of the crossable inner diameter that sometimes could be high, by 20 to 50%. And this is probably, for me, a problem. Could be sometimes a problem when I use the stent. That's why this patient is a patient that receives a Cre8 EVO, because I know that I probably use a GEC. We know that we demonstrated in vitro that this layout reduction could be in vitro, could be really harmful sometimes for the polymer coating of the surface coated DES. But this is not for the Cre8, because due to the unique technology of the Cre8, that is this amphilimous formulation preserved by the contact, by the friction with the inner lumen of the guiding extension catheter. As you can see in this microscan, with all the other surface coated, there is a large damage of the surface of the abluminal struts when crossing into the GEC, while Cre8 EVO seems to be really preserved. Starting from this hypothesis, I perform a study between compare Cre8 EVO with all the other surface DES, and I submitted this study I present the study with these results. The results are at 1 year, that we have a really statistical significant reduction of MACE for the population treated with Cre8 EVO compared with all the other DS. And for this, with the results in mind, we starting with an hypothesis to perform a study, a 1-2 propensity score matched analysis, in which we try to demonstrate, to test the performance of Cre8 EVO and the surface coated DS in terms of TLR and TLF at 1 year. So that I conclude saying that there is emerging and personal data that suggests the use of Cre8 EVO in case of PCI requiring GEC, because the use of Cre8 EVO may be beneficial considering the negligible interaction with the GEC inner lumen, and so far the Cre8 EVO seems to have a lower risk of damaging reservoir and consequently a lower risk of drug elution impairment and lower risk of major cardiac events in the follow-up. Thank you for your attention.
Thank you very much, Salvatore. So I remember last year discussing this theoretical possibility that the guiding catheter extension could potentially damage the polymer of your drug-eluting stent or your conventional abluminal drug-eluting stent, and by doing so would affect the kinetics of the drug. And now this year we are showing data, which is very interesting data. So we have a question from the audience. Before I go there, I would like to ask you, in your retrospective data set, do you check into which guiding catheter size did you use and whether that did play a role? I mean, I would suspect there would be 6 French, 5 French, 5.5.
In my study, we consider all the 5, 5.5 and 6 French guiding extension catheter in this case. Also, all the patient that was treated with these 3 size of guiding extension catheter was enrolled, was considered for the study, for the evaluation.
That's a very interesting data set. Hadesh?
Yes, thank you very much. So we have one question from the audience regarding the radial force of the Cre8 stent. Would like to handle that from the panel.
I personally, probably it's not for me because the radial force is the topic of the first presentation. Personally, I have no doubt on the radial force of the Cre8. So I use normally also in even in CTO, but also in really calcified lesion, because I know that there could be a very good results. And probably there is also one trick that in case of very calcified lesion, I would choose the Cre8 EVO, and that if I have a sub-expansion, probably there is some data that I can use all the device to expand or to post-dilate also the IVL, and without any risk of damage of the polymer, because there is not.
Thank you, Salvatore. Actually, we are going back to radial strength topic in the upcoming case. Before going that, I would like, by raise of hand, ask the audience, who is convinced that Cre8 EVO would specifically be a suitable stent because of these engineering features without having a polymer outside the stent that would be the stent of choice when you have to deliver the stent through a guiding catheter extension? By looking at the data of Salvatore, who is convinced about the data, or at least motivated to have preferential use of Cre8 EVO in that setting? By raise of hands. So you see, Salvatore, we need to do the study. There is only one here.
You convince a lot of people.
I have lots of work to do. Lots of work to do.
But there is already one colleague of ours who is already convinced. Who would like to participate in this study? Who would feel equipoised? You see, plenty of...
Okay.
Okay, there is still work to do, and that's probably the reason why we should come back next year on discussing this topic. With that said, thank you very much, Salvatore.
Thank you.
We go to the third case. And we have the privilege to welcome Dr. Ho from Singapore, who would show us another complicated case where radial strength is most likely an open issue to be discussed.
Okay, first of all, good afternoon, everyone. Thank you very much to CID for inviting me to share a case of complex PCI and ACS. So I have no conflict of interest to declare. So my patient is a male, 66 years old, risk factor of hypertension and high cholesterol, and presented to our hospital with inferior STEMI. And you can see from the EKG, clearly there's ST elevation in the inferior leads. So we took a quick look at the left coronary system, and you can see that he has a short left main and critical stenosis in the ostial left circumflex. And LAD was diffusely diseased from ostial to mid LAD. So the culprit was the right coronary artery. You can see a very critical stenosis in the prox RCA. It was very diffusely diseased. We had a kind of hard time to wire, so we quickly wired to one of the marginal branch and POBA with a 2015. And we got a Dimitri flow, and subsequently we were able to advance our wire into the PDA, and then we did further pre-dilatation with Scoreflex 22515. So we decided to perform intracoronary imaging. We did a limited pullback from the mid-RCA, as you can see, the pullback. And we wanted to know the plaque morphology, and you can see that mainly were fibrous, not too calcified. There was some calcium, maybe about 1 arc. And of course, when we do IVUS, we want to know about the size, the length, and then we decide on the our lesion preparation before we put in a stent. You can see that there is a cordon of calcium in from 9 to about 12 o'clock. So looking at the lesion, I thought perhaps because the patient was quite sick during the primary PCI, and this is our still images. So not too calcified, as I mentioned, so a lot of fibrous tissue. And there was an arc of calcium from at the prox RCA. So my strategy was to stent from ostial to mid with drug-eluting stents, so a hybrid strategy, and to treat the distal RCA and RPL with a drug-coated balloon. So I implanted the first stent in the mid-RCA at 3032, and then I use it to post-dilate the stent and also use it to prepare the lesion in the proximal segment with the stent balloon. But having done that, I created a dissection in the proximal RCA. So I have no choice. I have to quickly cover it with a short stent. So I implanted a short stent in the prox RCA. So I used a 3515-16 deployed at nominal, and then I post-dilate at higher pressure. And for the ostial RCA, I use another drug-eluting stent using the anchor wire technique, aiming for precise ostial stenting. So after we stented, you could see that there was still a waste in the proximal RCA. We did an IVUS pullback, and unfortunately, we probably underestimated the lesion. There was actually a calcified nodule, and the MSA that we obtained was 7. So the question is, are we going to do further? So how would you treat this? So we'd just like to open for discussion.
Yeah, thank you very much, Dr. Ho. Why don't we go through the options here? First was 3 stents implanted in a relatively short RCA with some residual, in fact, stent expansion to be fixed. So who, by raise of hand, will use a normal NC balloon? We are in Singapore. We have already implanted 3 stents. We are a very rich country. There are no issues. We went from Korea, where you cannot use more than 4 balloons, to Singapore, where you can implant 8mm stents as many as you want. So who would go for a non-compliant balloon, by raise of hands here? So traditional approach, let's say, non-compliant balloon, high pressure. Okay, I would say a very sizable proportion of us. OPN balloon is a bit specialized technology, high pressure. Okay, a little more limited choice. Laser, highly specialized approach. I've seen perhaps one hand. Laser, no, there was a mistake, no laser here. And shockwave, what about shockwave? Yeah, shockwave, it's also a good option as well. So please, show us what you did in Singapore.
So among all the options, I think I decided that perhaps we should try the shockwave IVL followed by an NC balloon. But then again, is there any concern when you do a shockwave IVL in a freshly implanted drug-eluting stent? So just like to share with the audience that there has been some in vitro study looking at whether there's any damage to the stent when you do a shockwave after you do freshly implanted it. So this is a very interesting study that was done by, I think, Dr. Sinilo in Australia. So comparing Cre8 EVO with other 3 major drug-eluting stents. And they look at the, under electron microscopy, look at the the polymer and then compare at the appearance at 50 pulses and 80 pulses. And because of the Cre8 EVO unique feature, we know that it has the it is polymer free and has the aluminum reservoir technology. You can see that there was no damage to Cre8 EVO. So when you do shockwave in a freshly implanted Cre8 stent, there is no damage. So the worry is when you damage the polymer, you will affect the drug availability, and that may affect the patient in terms of restenosis. And then another interesting study that was done looking at the how intact is the polymer and the drug. This was comparing Cre8 with Onyx. So you subject the stents to either IVL, laser, or high pressure post dilatation. Again, you can see that there was no damage to Cre8 EVO. So I think this is something that is very interesting because sometimes we are forced to do things retrospectively when we put in a stent. So how did I treat him? I decided to use a shockwave 3512. We currently have the C1, so we deliver all 80 pulses. And also I post-dilate again with NC Vecchio 4.0 and 4.5. So we were sizing it based on the IVUS. But because there was some worry that we damaged the polymer from the IVL and the post-dilatation, we decided to finish the procedure with a drug-coated balloon. So it's quite a controversial approach, but something that we thought that we should try to do for the patient. And we inflate at 6 atmosphere for 60 seconds. So we did a IVUS. You can see that the MSA has improved quite a lot. You can see that the final MSA has improved from 7.9 to 9.7. So we are quite happy with the final result. So this is the final result of the patient. You can see the stents are looking better, and we treated the distal RCA to RPDA with a drug-coated balloon with Dimitri flow. So the patient subsequently underwent PCI of the left coronary system. He had a preserved LV function and has been clinically well since January this year. So in conclusion, ladies and gentlemen, I think PCI of calcified lesions in the emergency setting can be challenging. We know that currently intracoronary imaging is class 1A in the ACC AHA guidelines and class 2A in the ESC guidelines. But like in my case, sometimes I think because of the acute MI setting, we can underestimate the calcified lesions and make the wrong judgment. And sometimes we have to do shockwave IVL of the freshly implanted stent if we get a suboptimal results. So I think looking back, I think Cre8 EVO would have been a better choice in emergency setting. Thank you very much for your kind attention.
Thank you very much, Dr. Ho. Are there comments or questions from the audience?
Yes, we have questions. We have the first question was regarding the presentation from Dr. Salvatore, and it was with the guide extension catheters. And the question is compelling, actually. The question is, how would a drug-coated balloon fare when shoved through a guide extension catheter? And because of the whitewash, Marco, would you like to handle this question? I think this suits you best.
I think Salvatore could do better than I can do. I will follow up on him.
So I personally have no data on DCB into the guiding extension catheter, but from this data that I have, personally, I do not use anymore the DCB in case I have a GEC or a PCI requiring GEC, because I am convinced that the crossing of DCB along the GEC in bands or in very tortuous vessel could be really harmful for the covered drug.
This is an emerging topic for investigation, I would say.
Absolutely,
And
absolutely.
I'm forcing myself to use more and more DCB, but every time I ask myself the question, how much drug is left when I inflate my balloon once I reach the lesion, which is something that's never been properly investigated.
Attention on that, and so probably we could have some data also for this topic.
But now Dr. Ho is bringing another topic on the table, which, to be honest, I never thought of. What is the outcome of using shockwave in an already implanted ES? What is the effect on the cracking of the polymer and the kinetics of the drug after shockwave? And your data are very interesting, to be honest. I was not aware of that.
Yes, this question was also asked from the audience.
And so, would you now change your policy? That's the way you concluded. So now, are you implanting Cre8 EVO every time you are planning shockwave?
I would say that we will prepare the lesion. Usually we prepare the lesion before we implant a stent. And preferably you would do the shock wave before you implant a stent.
But would you do shock wave in this lesion? There is a very limited amount of calcium there. So to be honest, your conclusion that I was has led to an underestimation of the difficulty of the lesion, it's very well taken. I would have not taken anything specific but perhaps a normal balloon in preparing that lesion.
Yeah. But I think the Cre8 is very useful for calcified lesions because we heard that it has very good radial strength. And I personally like it because there's markers. So sometimes when you insert something with markers, you can clearly post-dilate the stent. And the fact that if you, let's say you have to deploy a stent in an emergency setting because the patient is unstable, then I think Cre8 EVO would be a good choice because if you have to do things like shockwave, subsequently, you know that there's going to be zero damage. So I think something that we can think about now.
Yeah. And perhaps one final point to be discussed, Rino, 3 stents implanted, and then you're a bit unsure about the effect of shockwave, and then you use a drug-eluting balloon inside the stent. You are coming from the city of the Pope. Do you have enough money to do this or not?
Considering the money of Singapore, you can start with a normal balloon, NC balloon, OPN, laser and shockwave. You can use all, and you can see which is the first and the best one. But in this case, I think that the shockwave from the company, they assure that you don't have any strut damage. But in my experience, I looked at OCT or that you have always some damage of the struts. It depends from the when I use a rotablator for the implanted stent, I was used always to implant another stent. DCB, I think that it's a little bit soft. I don't know. This is my opinion.
I think data will tell. Nobody knows. So without any further ado, thank you very much, Professor Ho, for this very nice case. Then we ask Rino to present the 4th case, which I'm sure is going to trigger a lot of discussion. If anything, knowing him, I'm sure he will.
Thank you. Thank you, Marco. Thank you to CID and all the dream team of CID, starting from Enrico. May I have my presentation, please?
You have to ask.
Okay. Desk. Eccolo là. Okay. This is my presentation.
Yes.
This is my disclosure. This is a story of a 70-year-old male, Philippine-American ethnicity, hypertension, diabetes, smoker, and 2 important features, renal failure and peritoneal dialysis. In 2023, this patient developed a non-ST elevation myocardial infarction, inferolateral RCA. It was PCI performed abroad, out of country, with 2 synergy DES. Thus, it was a residual stenosis on left main LAD. Unfortunately, we don't have any documentation of this patient, but it was only an anamnestic history. But patient in that case refused PCI. And after that, the patient arrived after 2 years, several months ago, the emergency department of our hospital with a femur fracture fall due to a syncope and with a pulmonary edema, ST depression in V1, V4 leads, negative enzymes, normal, quite normal echo, 45%. The patient was still on DAPT. Why? Suspense. I will show you why. Thus, we perform an urgent PCI for a stable angina, and we classified this patient for the features of anamnestic features and for the ischemic features as high ischemic risk patient and high bleeding risk patient. This is the core angiography. First of all, right coronary, big surprise. This is the reason why the patient is still on DAPT, because in the previous PCI, it was a fractured wire, and thus the patient was, for this reason, still on DAPT. The actual chorangiography that we perform show a diffuse calcium on all coronary vessel, 70% of left main, 99% of the left circumflex ostium, 90% on LAD, and 80% on first diagonal ostium, very early arising. Thus, we decide to perform a left coronary PCI. We predilate the ostial of circumflex. Thus, we perform two debulking of the LAD with rotablator 1.5 and 1.75, a step-up bar. And then we perform an OCT that show the calcium crack you can see here and here in the after rotablator, after debulking. After that, the left coronary PCI, we implanted the Cre8 EVO 3 for 46 millimeter, very long stent on left main LAD. We performed a POT on left main, and then we perform a mini tap with stop technique. We inflated the balloon of main branch, and then we inflated the balloon of side branch, and we pull back the balloon until to feel some resistance. And we performed, we implanted the native Cre8 EVO 3 for 16 millimeter, and then we performed a final kissing. Thus, we perform a TAP usual technique for kissing, for bifurcation lesion. And thus we performed again at first diagonal DCB PCI with with DCB on first diagonal. This was the final result, not bad, and it was the very well opposed stent showed by OCT just after the result. But what happened? The patient, computer was discontinued. The patient was on ASA and cangular IV for 4 days. This is the flowchart of the last guidelines regarding the cangular for the patient that have been submitted to a major surgery. We met the orthopedic surgeon. They decided to make surgery after 4 days. Thus, cangular after 4 days was discontinued, and the orthopedic performed surgery on ASA, on SAPT. But 3 days after surgery, and still the patient on ASA, patient experienced chest pain and inferior ST elevation. Obviously, we perform a chorangiography, and the chorangiography, this is the aspect of the two synergy DES, while this is the aspect of the two Cre8 EVO DES implanted on left coronary. Thus, first of all, we perform an emergent RCA PCI. We perform a POBA to open the vessel. Thus, we try to make an successful wire snaring, because we didn't know effectively where it was this wiring. Something of the Superman moment. We tried to make this one, but it was unsuccessful, and then this was the final result of the RCA, and this was the comparison by OCT between the RCA and left coronary artery. RCA treated with two synergy, and left coronary artery treated by Cre8. And you can see here, if you can see the wire, you can see the distal tip of the wire that showed us that maybe this is the wire that will completely intrastruts, and that it was for this reason to catch how the wire, it was absolutely unsuccessful. But what is very interesting, that you can see at the OCT that after 2 years, the Synergy DS showed some uncovered struts. This is very interesting. While after few days, of course, all the struts of Cre8 EVO are visible, but after few days, some struts was covered. You can see here and here. I would show you this trial, that is Parthenope trial, that arise some concern on polymer-free Cre8 EVO with early stent thrombosis was arisen in this trial, but my daily practice, like this case, show exactly the opposite. But it's important to note that in this trial it was completely different, the results. Thus, I think that in HBR and ischemic risk scenario, Cre8 EVO DS showed an optimal performance in terms of both safety and efficacy. The abluminal drug release bioinducer surface that Dr. Won showed before and lac polymer lead to low DS thrombogenicity and fast struts endothelization, as you can see in this case, allowing a safe DAPT interruption whenever clinically needed, because sometimes we must interrupt the DAPT for surgery or something that you cannot expect, an unexpected interruption. And in my personal experience, believe me, Cre8 EVO is the best DS of choice in expected and unexpected HBR and ischemic risk patients. Thank you for your attention.
Thank you very much, Professor Sardella. Excellent case. I have to say, in Rome, you're also rich, pretty much as Singapore, but perhaps less lucky, because this patient got a stent thrombosis 2 years after Synergy stent implanted. So the question is, do you think that the wire left in place was playing a role? And second, why did you try to snare it? After 2 years, it would have been completely embedded into the prior stent.
I told you, the Superman moment.
Okay.
No. The Superman, no, but the first question is obviously, I think that the wire play a role in the thrombosis, because obviously, but the important thing is to see at OCT that it wasn't very important, the thrombosis of right coronary artery. It was very important, the OCT after the procedural result that show that after 2 years, some struts were uncovered. This is very important. The second, because we didn't perform an OCT for the wire, we didn't know that the wire, it was under the struts, and I tried without any, obviously, without any concept to try to make a snaring the Superman moment. I confirm the Superman moment.
Perhaps one, but there is one question
Yes,
from the audience, then I shut
we have
up.
questions for the audience. It's a very interesting and compelling question again. The question is regarding the Synergy stents that were implanted, if the uncovered stents that we saw could have been due to the fact of the high-pressure balloon dilatation after 2 years. So maybe it's, if I understand the question correctly, it's an artifact due to the ballooning of the stent. This is what the gentleman asked about the question. And if another stent was implanted by the same gentleman to the RCA, I understand that it wasn't, if I saw for your presentation. So again, the question, the uncovered struts on the RCA that we saw on the OCT, do you think that these could be due to the urgent intervention and the ballooning because of the STEMI?
No, I don't think so. I think that balloon, it's
very concise answer, thank you.
No, no, but because I think that we dilated the stent, the vessel, obviously, because it was quite an unstable angina for the patient, and we looked the thrombosis, and thus we did an emergent PCI, and for this reason we didn't perform an OCT to check the wire. And but I think that the balloon is absolutely not reliable with the correlated with the not covered struts.
Well, I think we have reached the limit of our session. We would like to close it perfectly on time, so let me exploit 20 seconds to say thank you very much to all the speakers and for the audience for this wonderful interaction. And last word from my side, a big thank to CAD for getting this symposium organized, and Enrico for being our Superman, in fact.
The dream team.
Thank you.